So just some general thoughts first. So a lot of people have shoulder pain, and they think, they get an MRI, and they say, oh, you have a torn rotator cuff. And what they found out is that tons of people, over 50% have a torn rotator cuff, and they don't have any symptoms. So one has to be careful of people coming in that get a doctor saying, so I have a torn rotator cuff. And the only thing you do is surgery.
Yeah.
So I do think that one thing that's really helped my practice, and you guys are physical therapists, is strengthening exercises. However, my strengthening exercises that I gave when I worked in PT, and most of my clients that come in, are they try to make things simple. So keep a pillow in here, external rotation against resistance. Again, therabands versus pulleys. Therabands at your most end where you really need the strength, it's sometimes too strong. So it doesn't have to be strong right here. You're better off there. Pulleys are better because you get a set amount the right way. I find external rotation for teres minor, for infraspinatus, the other rotator cuff muscles are better than this, but it's good to do this. I also do both sides, and it's better to do 2 to 3 times a day rather than once and overdoing it and training the nerves to work. My thing, I work with pulleys at my gym, and I go through all sorts of ranges of motion. So how many people do their movement like this? Their elbows are out, so it's fine to do this. It's time to turn it over when you're doing it. Fine to come down and do this. Up for anterior, deltoid. All sorts of ranges of motion.
Just making it more functional.
I'm sorry?
You're just making it more functional.
Yeah, functional movement. And so much of this stuff is not. I could talk about knee strengthening, but I'm not going to get sidetracked on that. So much of the knee strengthening has nothing to do with going down the stairs or up the stairs. Leg press, blah, blah, but I'm not going to get sidetracked on that. So first thing I do is, ask where it hurts, and I let my hands sort of tell me what I'm feeling in the musculature. I explain impingement versus frozen shoulder due to, other more structural things. Ask where it hurts, what activities do it. Quick one, frozen shoulder, a guy that was, God, he seemed really old when I worked on him, but he's probably just about my age now. No, he may have been 80. His daughter was a physical therapist, doing all this PT stuff. Nothing helped. He was playing tennis 5 times a week, and he used to beat most of his old codgers until he got frozen shoulder, because I sort of keep away from those terms, and then he couldn't serve. So he had to start serving underhand. All of his opponents would come in and put it away. So he was losing. And he was Scottish, and he came in and just sort of, I really liked him. He had that sort of Scottish. I don't want to be coming in 3 times a week. I want to figure out what's causing this and what I can do. And so I worked on him, and the stuff I'm going to quickly show here really helps. Oh, that's much better, much better. But I said, you need to strengthen his wife, his daughter. I said, you need to get the weakest TheraBand, and you need to tie it up to something up above, because you're fine, and down here he was fine. So a lot of these strengthening exercises, the arm is down. So I said, you need to tie it at an angle like this. I got one and did it at my house. And I said, now you don't want to make any of this hurt. So right now, you're going to do a range of motion like this, but you're going to use the weakest TheraBand, and you're going to go through the serving motion. And you don't have to go all the way down. You can, this is your range for hurting. And then more and more, you need to come back here and do it. And then pretty soon, just go through your motion with your tennis racket if it doesn't hurt. so that if it hurts, it's going to call in those inhibitory responses. So, I probably saw him 3 times, and that was it. And then pretty soon my phone was ringing, and it was all these guys that were 75 and 80 years old. They were up at the tennis courts, and he was back to beating again because he was serving overhand. So, well, I've got this knee, and So, functional strengthening, stretching, see if they are limited in internal rotation or external rotation. So I test them first, left hand, right hand, have them reach up with one side, reach up with the other. Usually there's a difference of about that much. And you make it all possible. Oh, great. Look how inflexible you are here. That's not going to hurt a frozen shoulder unless they do it too hard. Have to emphasize pain-free, easy stretching and strengthening. And say, okay, now this may take 3 months for you to be equal, but a little bit at a time, 3 to 4 times a day, and I always make people not feel guilty. Sometimes 3 to 4 times a day is, oh, God, I don't have the time to do that. I'm just not going to do that. So if you miss a day, don't worry about it. If you miss 2 or 3 times a day, but try to do this frequently. Do it when you're warm, not first thing in the morning. So you guys know all the PT stuff. Go in the shower, have a towel, and do that. We'll run the shower on this, warm it up, put on a heating pad before you do it, and give them all the stuff that you want to give them. As far as testing, I do most of my testing on this when they're not holding up in gravity. So I have them lie on their back first. I do both sides. I often start with the non-effective. I rarely see frozen shoulder in both shoulders. But what I do see often is one shoulder resolves and the next one comes in. Have you guys seen that? I see it frequently. And I think it's the brain. Something's talking again and then the other one. So I see that a lot. So first thing I do is I test. Do you have one shoulder that you have any issues with? You're left-handed, I recall.
Yeah,
right?
left-handed. Yeah.
So you do most of your punching, but any differences?
Yeah, I can sometimes feel when I do the left hook, I can feel a bit up here.
Okay, so I'm really clear because it is not a frozen shoulder thing. A lot of people think they have frozen shoulder, and it is biceps tendonitis.
Yeah.
And so I'm real clear about the bicipital groove. I do a little medium touch. Oh, yeah, that's really sore. Oh, good. Good. That's biceps tendonitis. Now, that's not related to a rotator cuff tear. Try to keep everything positive but honest. Okay. So I'm going to start with her. She's probably pretty even, and I imagine she competes at an actually a world-class level in what's the specific?
Thai boxing.
Thai boxing. So she's probably been doing a lot of exercises. Anybody that's beyond this, I'm not going to work on external rotation. Because the more you move here, the more vulnerable you become. The other thing I've found, it's really interesting because of how this fits in here. I used to just test up here, but I see some people up here, and they're fine, and we do it down at 45. Look at that. So figure out, most people will be fairly good here and not up here. So I would be doing a lot of work in non-raised to get that going.
Yeah.
Then I test internal, and I make sure that their elbow isn't down and back here. I can bolster it, but I usually like to hold this down. I can have it slide over. I hold the shoulder down because we're not testing scapular movement. So we want the scapular move, but I've also known that people with overmobile scapulae are prone to this. So I had a client a student 20 years ago that we were demonstrating shoulders, and I said, I'm going to choose another model here because I don't want any more flexibility here. That makes you vulnerable. She says, oh, I'm a volleyball player, and I've been having trouble, with this. And so that's what we do. So I hold this down in not too far, neutral, And so she's, relative to external here, she's a little limited. So working on this, down this way, if somebody's really pretty weak, give them a 1 or 2 pound weight, tell them to just read a book, lie here, let that go. I find, particularly for internal rotation limitations, I find careful not overdoing it, P&F stretches. Because so much of this is a semi-conscious or spinal cord reflex. So hold it down, have them push up, don't let them win, then, and I find that super effective. So let's just test over on the other side. And then if you find difference, you say, oh God, yeah, I think, we're just going to work toward this goal. So we take her up here. Remember, she went all the way down to here, not quite as far. Okay, so this is not bad, but if you're having to take your arm back to do something, that's vulnerable. So the stuff we did yesterday about taking pec major, lifting it up, rolling it, coming up here, the stuff we did on pec minor, get the front going, get the triceps in back, deltoid running, and I'm pretty sure the way I feel with her is that it's soft tissue. It's not a bony thing here. So just a couple moves very often is all you need. Nice soft fist. Don't forget, pec major is an internal rotator. So working in this position with pec major to get this. Play around with, if you think it's more joint capsule, play around with compression of the joint to slacken ligaments. How does it move best? Pull back, decompress the joint. See what works best for you. Now I've felt some softening there, so let's just test. You don't need a lot of work. Okay? Don't overwork.
Yeah.
But no sense spending more time. And I don't want to, even if she's still up here and she started here, don't go for perfection. So the troubles I've had in my work over the years are I try to do too much. And I had a guy, long story, he was swimming to quit smoking. And he smoked all his life. He had to swim every day. It was like somebody having to go to an AA meeting every day. Came in with the shoulder. You got it moving so much better. He said, yeah, but they're just little. Can you? Okay, because I don't care about time. I just, I just didn't want to work. No. I'm a day later he calls, oh, my shoulder's gone back. It's worse. It's a rebound. And he's panicked because of the smoking, and I've learned from that. Okay, so external. I think that'll stay for you. Okay, hold this down, and I think I can tell. This is everything. Start playing with yourself to refine your sensitivity. I haven't even come close to in range of internal. Just from picking this up, I don't think you're going to come nearly as far down. So we let it go. Whew. Man, now I do want to show you a bunch of techniques, but this, I don't just been doing testing. I'm going to work on this. So I want to start slowly. I feel posterior soft tissue is holding it. I feel capsular. So I often start with the capsule. So I do joint mobilization. So I'm sliding the humerus posterior, just soften this. It'll make her feel good. It'll make her feel a little safer. So we're going to do this first a little bit just to see what that does, because it's a combination of capsular and soft tissue. So I'm mobilizing it posterior. Most frozen shoulder is the humerus is too high up. So it's drifted up. Terry's muscles aren't doing their job of stabilizing and pulling the, not femoral, the humeral head down in here. So I want to mobilize the humerus down, okay? So nice soft hands, keep the elbow here. And this takes care of all doing this before they may be really worried about their joint. And you start going slightly different angles. I'm sliding it down. Then we get a little more functional. So then we go up, down, up, down, up, down. The key is how hard to do this. You don't want to be wimpy, but you don't want to overdo it, okay? I don't usually do much this way. I can move it forward just to free the shoulder up in prone position, which we're going to do. So now we're going to hold this again and just, then I can tell. So I often go to what I call secondary issues first. So instead of saying, oh, these muscles sore, we do this. Oh, wow, that was the answer. So we're going to do the same here. Going to hold this. So as I say, the reason that I was lucky, as I say, I'm not by any chance some great skill on this, is that I've asked people and I experiment and I work and I test and I work and I test. So in PT, they do a test before. Everybody's really cold. They come in, their shoulders frozen. I don't mean, it's cold. And they measure, they get their calipers out, and they do this. And then they put on heat, and they do all this stuff, and then boom, it's down. So they think, boy, that PT's really homely. Well, if they'd gone out and moved it around. So that's significant. But I do feel a lot of stuff in deltoid here. So I work with movement as I'm working, but I do not force it. Okay? So some other things real quick. We're into 9 o'clock, but I think you can see how effective it is. And I don't have anywhere close to this amount of success with most people I see. So don't think, oh boy, everybody sees his shoulder goes through. No, a lot of people, nothing's happening. She doesn't have frozen shoulder. She's very trusting and such. So don't try stuff and say, oh God, I'm doing something wrong. That's not what the situation is. So internal, don't forget, I bet you she's pretty good here, down. So unlike here, where she was limited in external rotation more down, look at her here. So if I sit here and try to measure internal, she's fine on internal. She's not when she's up here. Okay? I really get a lot. You're going to do pec minor work that we've done. You maybe check her scapula, because we don't have a ton of time here. Scapular stabilization exercises. Rolling, isometric, things like that. I get a lot right where the clavicle comes in here, and it just gets gunky in here. So soft finger, sink in. Upper trap, usually hers goes forward a little bit. So upper trap, don't forget it isn't just lengthening upper trap. Upper trap gets rolled. So I often have them turn their head. I get on the border, I take my hand on the scapula, push the scapula down, and roll that trapezius. You could have her lift her head a little bit to put a little more stretch on that. Down there, do a lot of Terry's work. Get the arm up here. Remember, it comes from behind. Get Terry's major back here. Keep moving up. Now, I did a demonstration, maybe it was yesterday, and, right, yeah. So he had all this strength and tightness down here. We go, and look how free that is. Okay. He also resists. But remember with him, but maybe she doesn't need it, roll that scapula, work on subscapularis in here, nice and easy. Go in there, have you raise her arm up that way. Yeah, back and forth, and
like
back
that, yeah.
down.
Like that, okay. Yeah.
Okay. And then one that you can access rotator cuff this way. I find it. I have people reach across See how it feels. Oh, the other thing is, very often, it's back here, particularly in external rotation limitations. So I get in right in the posterior capsule here and work along that capsule and move the arm up. Okay? So I'm following through there, but reach across, you can get all these. You can get infraspinatus, your tendon here is pretty tight. So, and you have her reach across your body that way. So you work this way, you work posterior deltoid this way, triceps, get this arm freeing where it can move without the whole body going. So you might even stabilize the body as you do this. If you feel the scapula is frozen, then you get under here and you pull the scapula out. So you see where it's not moving. And then a quick turnover. So we'll go back on the other side, since that's check the scapula. A lot of people, in massage particularly, we did all this massage training in my early training, and I'd always feel like, oh God, I'm not worth a darn, because the teacher would pick the 17-year-old yoga teacher and move through all these motions and get her hand all the way up to the elbow through here, and I'd come in and can't get in there. And my general rule on medial scapula is, we'll be done real quick.
Yeah.
Yeah. Is if you
keep on going.
Okay, if you can get your fingers into the third knuckle in there, it doesn't need it. So if you can't get in there, it needs it, but you're not going to be able to get in there. So, no, but test axis of rotation. Remember when she's raising her arm up, rhomboid down here has to stretch. Okay? So I do a little thing with my beginning massage therapist. I say, if I want to lengthen the rhomboids, do I have the arm down or do I have it up? So everybody gets into this way of thinking, oh, down or up. And they don't realize that the rhomboids work differently. If we're raising our arm up, the upper rhomboids have to contract, lower have to distract. So you can do this in your chair massage. Get into those rhomboids and have them move their arm up and down to free this. Okay? So I see more problems with tight outside here, subscapularis, fascia. So on this, I don't come in on any of this stuff with pokey thumbs. So I sometimes overlap. I'm getting my power here rather than, again, as I keep harping on that, don't use your muscles. Let's check those eyes. You're feeling better. Okay, so I come in, just rest my own body. I get on the inside border and roll underneath the scapula and lift and roll and rotate. See, so and depending on how hard you do this, this can really feel good. Now I might want to get under here and have you move your elbow up this way. Oh, okay, now, no, just up towards your head.
Okay.
Yeah, and back down.
Yeah.
And back up, and back down. So that's pretty uncomfortable right where my thumbs are.
Yeah.
Okay, scale of 10?
Oh, it's around maybe 5.
Okay, I would have guessed about 5. I could get up to, I'm usually pretty, I just sense the body. I like to work at 7 maximum. So this would be 7 for me. Okay, bring it up.
Yep.
Am I up to 8?
Yeah, around
Okay,
7, 8.
okay, so then I say back up. And did you feel Terry's minor coming in?
Yeah.
Okay, so asking for movement, you will find what muscles are problematic when you won't in neutral. Okay, so I, of course, am going to maybe turn her head to the other side or have her in here. I'm going to work on this line all the way up to the head, all the way down on upper trapezius, okay? Come down here, work on lats. Remember, lats are an internal rotator. So if we have trouble with external rotation, then we got to work on the internal rotators that are preventing that. So lats can be really good to work on here if she's having trouble in external rotation. So another thing I like to do is three-dimensionally. I come under here, boom, nice soft hand. I have my hand on her humerus, not her shoulder blade. And in this position, I can distract the shoulder, compress the shoulder, internally rotate the shoulder, and my table's higher when I get this, come through, externally rotate the shoulder, bring the shoulder back this way, okay? Somebody that's got trouble reaching across that we worked on when she was face up, you can have her slide all the way over, not your lower body, just your upper. And get a little bit further, you can work front and back, you can get on that pec major, but we start distracting this joint as we're working on the tissue. So I pull out and move this in. Feel any muscles that are tight there. Have her bring her arm up. Lower muscles here, serratus posterior. All the way up here. So this started out as frozen shoulder, but any athlete or anything, she doesn't have frozen shoulder, but most of you weren't here when we were doing particularly internal rotation on this. Joint mobilization. So I didn't want to get in and do all this fancy stuff. I just did some simple joint mobilization. That arm went. It's just fun work. Do it. I'm pretty careful about this one. So a lot of massage therapists learn this. I think it's limited. It's good. You can see what the shoulder, it brings this out if you want to. If when you put your hand here and this scapula pops up like that, you don't need to work there. She's, if anything, hypermobile there. So it can be a way to excluding. I said the key in doing deep tissue work or myofascial or whatever is knowing where to work, when to stop. My thing is stop that. Don't go any further because I'm too much of a perfectionist and I want them to go further and I overdo it and I overwork or something. And the other is where to work, when to stop, where not to work. Why waste time? Because I can get under here and it looks pretty cool to have your fingers in there. And I've wasted 4 or 5 minutes in work that is not only not needed, but maybe is actually over-mobilizing and unproductive. Okay? So that's a lot in the shoulder. I would take 4 hours at least in a workshop where I'm doing shoulder. I'd take at least 4 hours to do that, maybe 6, the stuff I showed there. Okay. That's including you working, of course. So that's good. Any questions on that? Yeah.
Question completely aside, when you give treatments, and you mentioned yesterday when the client is spaced out. After the treatment or after intense massage, sometimes the client is spaced out. And you mentioned the nervous system is because one was working on the. No, is it because of that, or what's your?
Yeah, well, see, a lot of it depends how you work. So a lot of PTs at this one particular thing, they got patients lined up like railroad cars, coming in. In my private practice, I think that's good. So why don't you lie there on the table 4 or 5 minutes, and that usually means 2 minutes for most people. They want to get out of Dodge, but say, why don't you just breathe and let that sink in for a little bit. Most people put ice on, but then I look at people up, I come back and say, okay, move that around. It's just my practice. People feel like, if it's done, I'm off the payroll. But I say, there's still a little kink there. And so say she's got a shoulder. And I say, come on, stand up and tell me how that's feeling.
Okay.
I also think shoulders are always, there's always a component of neck involved. I'm not saying cause effect, but I always work on necks when I'm working on shoulders. So I say, just move around through your range of motion. Tell me if there's any kinks in there or any areas that...
Now I feel the right.
Yeah.
Yeah, so this is nice. I feel like, normally I feel like my shoulders is like,
Yeah. Okay. So this is what I do in a session. I don't book closely. I don't book that much anymore. I do it mostly for fun. So let's leave her a little bit balanced, not only in her body, but in her brain. So I've been stimulating, we've been working on her left side, I've been stimulating her right brain, which is talking to that. So let's just talk to your other side, and I don't want her having to get undressed on the table, so why don't you just sit in the chair there, come in here, just say hello to this. I feel something, so there's some gnarliness right there. Rotate this back. Now tilt your head to the left.
yeah.
Rotate to the left now. Great three-dimensional work. So I can take her arm up here. I can do some more joint mobilization. So I've got this humeral head, depression. So I'm moving this up, getting that joint going down in there. Definitely posterior is what I'm working for. Slide this back, take her arm up here, reach behind her, come here. Just get playful. Just, this seems like there's a little kink there. Let's work on that, Just try different ranges of motion. Again, try internal rotation up here, down here. Distraction, compression, come across the elbows, triceps, squeeze it up. Put that down, back here, tie it in. Oh, there's a rib right there I want to say hello to. And then she thought she was done. So particularly for massage therapists, I tell Lisa, Kay does this. She finishes, people have their clothes on, leaves, lets them get dressed. How are you doing? Great. And I've seen this particularly with people who have their shoulders up. They're on the table, we work, and they get up, boom. And so, say, oh great, I'm good. I think some of this is just your pattern. So notice how those show up. Can you let them down? And then I'll say, please sit this chair. And sort of loosen that up and you say, okay, I want you during the day to just flash back to this right now. I want you to picture my hand on here. I'm not cranking that down. Just. Another thing, I can just go on forever. We're already 17 minutes in. Don't forget the elbows. I tell people in classes when we're working on upper trap, levator scapula, say, okay, let those arms go. Okay, now I want you to really tighten those elbows. Just lock those elbows. Okay, now let your shoulders go. Can't do it. Say, so a lot of your shoulder tension, you see people walking, this is when I do body reading. They're walking along like this or like that, and you want to see all over the body. Foot to ankle, ankle to leg, leg to pelvis, pelvis to back. You want to see movement through there. And anything that you don't see moving, get it going. And so elbow work is actually pretty helpful for shoulders. Questions? Okay, let's get the computer Down here.
These are
Sure, sure. Oh, sure, sure. That,
because we have here.
oh, okay. Okay, that, why don't you, as I'm setting this up, I'll get this going. Why don't you talk to them?